Good afternoon, and welcome to the CDP webinar, Ebola, Responding to a Global Crisis. This is Brennan Banks, Director of Recovery Funds here at the Center for Disaster Philanthropy. This webinar is provided with generous support from the UPS Foundation and is co-sponsored by the Africa Grantmakers Affinity Group. This webinar is part of our new series focused on raising awareness of and responding to global disasters. A few reminders before we get started. This webinar is being recorded. You can submit questions at any time using the Q&A box, and they will be answered at the end of the panel presentation. Please do not use the chat box. If you are on Twitter, please use hashtag CDP for recovery to share the discussion. To begin, I want to provide some background on the Ebola epidemic. The current Ebola outbreak in the Democratic Republic of the Congo was declared an epidemic on August 1st, 2018. It is now the second largest and second deadliest Ebola outbreak in history. And some experts, including those you will hear from on this panel, feel that we are at the tipping point of sorts. Either current measures are proven to be successful and the virus is contained, or it will spread into neighboring countries and cases will rise dramatically. In recent weeks, the number of cases and deaths have been growing at rates faster than witnessed previously in the crisis. While this outbreak is significantly smaller than the West Africa outbreak of 2014, which killed more than 11,000 people, as of May 14, 2019, the World Health Organization reported more than 1,739 confirmed or probable cases with 1,147 deaths. The Democratic Republic of the Congo's National Institute of Biomedical Research confirmed in early August that this outbreak is caused by the Zaire Ebola virus species. This is the most dangerous strain of Ebola viruses, and is the same strain that occurred in the 2014-2016 Ebola outbreak in West Africa. There is no cure for the virus, and the fatality rate once it is contracted is 66%, higher than the average for Ebola cases of 50%. Of those affected, nearly 55% are female and almost 30% are children younger than 18 years old. Healthcare workers make up 6% of the total cases. 95 have been affected, including 34 deaths. Delivering vaccines and healthcare in an area filled with conflict is tough. Yet, approximately 111,494 people have been vaccinated, all of whom were contacts of infected or deceased individuals or contacts of contacts. We know that this emergency, like the 2014 outbreak, which lasted 2 years, is going to need support from the entire international philanthropic community. We also understand that for many of you, responding in an international context might be new. So we will be providing information about how best to ensure your donation or grant is put to the highest and best use. To update us on current emergency response work in the DRC and what funders can do to help, we have with us today the following speakers. Peter Graff is the Senior Representative of the WHO Director General for the Ebola response in the DRC and joins us today from Butembo. He has spent over 25 years working for the WHO and the UN Secretariat. In October 2014, Peter was appointed as the Ebola Crisis Manager and later Acting Special Representative of the Secretary General for the United Nations Mission for Ebola Emergency Response, UNMER. In Liberia, following the closure of UNMER, he served as WHO's Regional Interagency Ebola Crisis Lead. In March of this year, Peter was appointed as a Special Representative for the DRC Ebola outbreak. Paula Olson is the Program Manager for the International Medical Corps programs in West Central and Southern Africa and oversees the organization's Ebola response in the Democratic Republic of the Congo. Based in DC, Paula has traveled to the Congo in December of 2018 and again in February and April of this year to support IMC's Ebola response and prevention efforts. Gabrielle Fitzgerald is the founder and CEO of Panorama, an action tank dedicated to helping ambitious leaders solve global problems. Prior to founding Panorama, she directed the $100 million Ebola program at the Paul G. Allen Family Foundation, investing in creative approaches to combat the Ebola outbreak in West Africa. Gabrielle previously served as the Director of Global Program Advocacy at the Bill and Melinda Gates Foundation, leading the team that advanced policy and advocacy agendas for the organization's global issues. Also joining us, we have Dr. Scott F. Dowell, a pediatric infectious disease specialist by training, now focused on tracking the causes of global childhood mortality for the Bill and Melinda Gates Foundation. He joined the foundation after 21 years at the U.S. Centers for Disease Control and Prevention, where he studied viral and bacterial pneumonia and responded to outbreaks of Ebola and other pathogens. Scott was deployed to North Kivu in the DRC last September and leads the Gates Foundation's current Ebola response. I'd like to welcome and share our thanks to the entire panel for taking time away from their work on this disaster to speak with us today. Paula, I'd like to begin asking you a few questions. I know you have been to the DR Congo 3 times in the past 6 months. Can you give us an overview of what you have seen on the ground? What is the overall situation like, and how has it changed over these last 6 months?
Thank you, and thanks again for inviting me to speak on this panel. If I may, I will introduce a little bit more about the context of what we're seeing on the ground and go into answering your question. So on August 1st, 2018, the Ministry of Health in the Democratic Republic of the Congo declared an outbreak of Ebola in the eastern province of North Kivu. And after the investigation of 26 cases of acute hemorrhagic fever, they decided to make that alert. And so to date, as you can imagine, we've gone from less than 10 cases, confirmed cases in the months of September, to more than double digits now, growing into this 2019 period. So as you mentioned, I've gone to DRC now 3 times. The first time I went was in December of last year, right before the presidential elections. And I've just returned from my latest trip just a few weeks ago. And certainly I don't think that anyone anticipated that our response efforts would be ongoing up to this point. But unfortunately, between then and now, the confirmed Ebola case count has exponentially increased. Right alongside this increase in Ebola cases are the ongoing security concerns that have continued to grow over the past couple of months. There are more than 100 armed actors in the DRC, and especially in this particular province. And while I'll dive into that a little bit later, this has had a huge impact on our response effort and, of course, the safety and security of the humanitarian community. One aspect that remains consistent is the community resistance to Ebola efforts. Ebola is highly stigmatized, as you could imagine, just as it was in the West Africa outbreak. And many community members still don't understand the realities and the seriousness of the disease and don't seek medical attention fast enough. And so as a result, we in the international community have scaled community engagement activities to make sure that we're educating them on the importance to seek health care quickly in sites like Ebola treatment centers or screening centers that we have, which International Medical Corps runs. I think another really important thing that's remained consistent is just the impact and the efforts of the men and women who are on the front lines every day, really literally risking their lives to continue to support confirmed and suspected cases and those community members.
Thank you for that, Paula. And, for some of us that, have been in the field working in this type of environment, in this type of emergency, we can understand that it requires a lot of coordination, a lot of communication on the ground.
Absolutely.
Can you tell us a little bit about IMC's role in terms of who you're working with to really support coordination and communication on the ground, and maybe share some of the challenges that you and others might be facing?
Certainly. And so I'll take this opportunity also to further introduce International Medical Corps. So International Medical Corps is a global first responder to disaster relief, working in over 80 countries over the past 30 years or so. And we're one of the few organizations who responded in the 2014 West Africa Ebola outbreak. We've been working to address the outbreak in DRC since its start in August 2018, and we are among over 59 organizations, both a combination of international humanitarian organizations and local actors that are working on Ebola in the provinces that are affected. So other actors present on the ground include, but are certainly not limited to, the Ministry of Health, WHO, ALIMA, Mercy Corps, IRC. These are probably names that some of you recognize, and of course MSF, Médecins Sans Frontières. And the way we work is we work along key priority areas that have been defined by the strategic response team there. And what International Medical Corps specifically works on is treating Ebola patients, screening for Ebola suspected patients to prevent the spread of the disease in health facilities as well as the community. And actually, so far, we've supported over 900,000 screenings for Ebola. We train frontline workers on proper infection prevention and control to make sure that the spread does not occur in health facilities. We engage with community members to educate them on the realities of Ebola. We're providing safe water and sanitation in communities and health facilities to prevent the spread. And we're also, and we're very proud of this, involved in looking at new treatments for Ebola. International Medical Corps, among other actors, are taking part in the first random controlled trial for 4 therapeutic treatments. So this is the first time this has happened in our history in both an active epidemic and a conflict zone. We're very proud of our team that's composed of international experts on Ebola that were also involved in the West Africa outbreak. And, we've been able to harness kind of the lessons learned, as well as the national staff who are really critical to ensure our teams are supported and aware of the needs of the communities we're working in. And I think that's really a particularity about how all humanitarian actors are working, is we're working with the national community, and not just national as in Congolese, but national as in local to the areas, which has been very, very important. In terms of the challenges, there are many, but I'll just mention a few. The biggest challenge that our teams are facing are the security concerns. This is an active conflict zone, and we can't forget that, and that really complicates our response. However, it hasn't stopped International Medical Corps or other humanitarian actors' ability to implement quality programming or tend or care to suspected and confirmed patients. But it is a major concern that we all need to be aware of. Our frontline workers have actually faced threats, and facilities have been damaged as a result of this community resistance and also by these armed groups. Another challenge we're facing is just, the sheer scope of how this is being spread along amongst the area. Now it's been spread to over 18 health zones, and 2 of those are major urban centers. One where you mentioned Peter Graff is in now is Butembo, and also Beni. So that's a major concern. It's just trying to get that under control. And one that I think that now we're aware of, because he's not able to join us, is also the connectivity issues between the different platforms, the communication systems that are often poor. So it's difficult to connect between different sites that are across these different areas. And I guess the last challenge that we're facing is really resource scarcity. We do need supplies. There are many resources that we need, and we rely on the international community to help us in solving. Amongst them are financial resources, human resources, but really supplies. We have to have protective gear, and only certain types of protective gear. So, WHO and other agencies have really been instrumental in us getting those resources, but that remains a challenge.
Thank you, Paula. And we're hoping that Peter will be able to join us, but he is having some technical difficulties. But we're hoping that he'll be able to join us shortly. Both you and Gabrielle mentioned that you felt that we're reaching a tipping point. And if I may, I might shift gears a little bit and ask Gabrielle to jump in and ask Gabrielle to basically talk a little bit about how or why you feel the crisis is at a tipping point, and maybe just give us an idea of what you feel the next few months might look like, or the direction of the current crises might evolve. Gabrielle, can you hear me? You're on mute. Maybe just check, Gabrielle, if you can hear me okay. There we go.
Okay. Am I on now?
You're on now. And I was just to come back to it, I was just when we spoke before the webinar, both you and Paula mentioned that you felt the crisis was reaching a tipping point. And I was just wondering if maybe you can share your thoughts about that, and what is your sense of the next few months and what it might look like.
Great. Well, thanks, Brennan. Thanks, Paula. Thanks to everyone for joining on this important topic. So the reason that a number of people are thinking it's at a tipping point is that the trajectory of the case counts that we've seen in recent weeks is mapping to where we were in 2014 when the numbers started increasing exponentially. And I thought it might be worth going back a few minutes to the 2014 outbreak response and talking about how philanthropists engaged there and some of the lessons we might learn for this outbreak. As Brennan mentioned in the introduction, I was the leader of Paul Allen's $100 million Ebola initiative in that outbreak, although I didn't join until a few months into his outbreak response. So when we look at 2014, just to remind everyone or tell everyone, the outbreak was first identified in April 2014, and the international community came in and responded and kind of then took a sigh of relief, thinking that the outbreak was under control. But just a few months later, Ebola came back with a real vengeance in the summer of 2014. And up until that point, there was very limited global attention and funding commitments until around late September. And the issue was addressed at the United Nations General Assembly meeting. And just a few weeks later, the US government named an Ebola czar. So things were really starting to increase in terms of global political attention. And the following week, Paul Allen announced that he would commit $100 million to the response. And so that was the largest philanthropic gift to the response. And the combination of those events, plus the fear of a widespread outbreak, led to a significant influx of philanthropic capital in the Ebola response in 2014. And so I want to share a couple of reflections on that as we sit here today at that turning point that we're perhaps very analogous to where we were in the summer 2014. So while it was wonderful that there was a significant response from many philanthropists who hadn't engaged in global health or international aid before, the funding was really diffused to a lot of different organizations across the 3 affected countries. And it's really important to understand that when responding to a disease outbreak like this, there's a high degree of command and control infrastructure. And that in this case, the the World Health Organization and the Democratic Republic of Congo have worked very closely to create that overarching plan that all of the partners are falling under. And while in the West Africa situation, because it was so geographically widespread, there was room for other partners to come in and do kind of good work or shore up the general health system. In this case, given the volatility of the region in North Kivu where this is taking place, we really need to focus resources on the groups that are there at the heart of the response, as Paula just described IMC's role. So when I reflect back on the outbreak, it wasn't clear that all of the new philanthropic capital that was coming in was used for the highest best purpose and for central core response activities. So I'd say there was three things that we learned from that outbreak that apply today. So first, in an outbreak situation, early investment is key. The longer you wait to respond or invest, the bigger the problem potentially becomes. There also is an important role of philanthropists in spurring greater engagement from government donors. And part of my role in working for Paul Allen was talking to governments and other philanthropists to encourage them to do more. And by the end of the response, not attributing it to Paul Allen, but it was a true widespread coalition of donors, funders, partners that had come together to work on this problem. And then the other importance is that important lesson was the importance of philanthropic resources needing to be concentrated. So I hope that sort of reflection of where we were 5 years ago and how it relates today is helpful to everyone on the phone that's thinking about what role you might play. So kind of turning to today, the strategic response plan that was created by the WHO and the Democratic Republic of Congo Ministry asked for $147 million for the 3-month period of February through July. And however, they've already said that significantly more funding is needed. And I think as we are at this tipping point, there's probably still an even bigger budget need. So as we look at, is there a need for philanthropic capital today? Absolutely, yes. But as you're learning about this and thinking about this, I would really encourage philanthropists to think about really concentrating that capital in the finite number of organizations that are on the ground there who are part of the official strategic plan. And to support that, I'll be setting up a philanthropic fund for Ebola to make sure that resources are pooled and deployed to the highest, best use of the response at any given time. So I'll stop there, and Brennan, happy to answer any questions at the appropriate time.
Thank you very much, Gabrielle, and I'm really happy that you walked us through, your and our experience in 2014 with that outbreak, and it's really important to talk a little bit about, the work around the philanthropic community or within the philanthropic community during the 2014 outbreak. Could you tell us a little bit more about what philanthropic strategies you think would be important for the current outbreak, and how could we convince more funders to get involved?
Well, so I have a lot of opinions on that. So I think, I would look at it in concentric circles. So there's the need for the capital to support the immediate response. And as I described, the sort of command and control structure of what is happening in the official response. However, what we saw in the West Africa outbreak, and there's huge parallels to where we are today, is the philanthropic funding that came in dried up immediately after the outbreak ended. And so the communities that had been really battered by Ebola were left with weakened health systems. And so for a philanthropist who is less comfortable with doing the emergency response, the support for general health systems in this region is certainly very much needed. I would say there's also the need for shoring up national capacity for emergency preparedness and response, and that's kind of a different way that one could think about it. And then at the end of the Ebola outbreak a few years back, there were many papers written and commissions convened, and I was part of many of them. And there was a lot of recommendations that sadly have not been heeded. But some of the recommendations were around investing in research and development to get vaccines, drugs, and diagnostics developed and across the license finish line so that they were available for the next outbreak. There was also a lot of questions around the basic science around Ebola that we still don't understand for sure which animal is the vector, what causes outbreaks of Ebola to start and flare up, how long does the virus remain in bodily fluids. So I would say there's a pretty broad menu of things that a philanthropist could invest in to both respond directly to the outbreak today, think about some of the longer term health systems issues, and then some of the longer term scientific questions. So there's a lot of room for impact should you be so inclined.
Thank you, Gabrielle. And I think that's so important to note, as we talk about the current response needs and look at various philanthropic strategies, we can't overlook the fact that there's still a lot we don't know, as you said, about Ebola, and we need to ensure that we're also making investments in developing strategies that are supporting research, and at the same time, as you mentioned, supporting local health systems and infrastructure. Scott, as we talk about various philanthropic strategies, can you tell us a little bit about the Gates Foundation? And I know you've been an active player in combating Ebola for several years, but tell us a little bit more about what the Gates Foundation is currently doing in the response related to the current crisis, and what type of activities or initiatives have you funded to date?
We are engaged in the current response, and in fact, the Gates Foundation has not been so active in Ebola in recent years. We stepped up in the 2014 outbreak, along with others like the Allen Foundation, when it became clear that was a clear unfolding disaster in West Africa, and committed funding and personnel time to help respond to the 2014 outbreak. But after that wrapped up, really folks at the Gates Foundation were told to get back to our day jobs, and we didn't have a dedicated committed initiative focused on Ebola, but retained a small team focused on epidemic and pandemic preparedness in case this came up again. And beginning in August and September of last year, when the North Kivu outbreak began to unfold, it was clear to us that this could be a problem as well. And so the foundation did commit some funding to WHO for a fast, flexible response, and we have supported the use of sequencing of Ebola virus isolates to better understand the epidemic in the subsequent months. In September, WHO leadership asked for a deployment from the foundation to North Kivu to help with the response, and I was sent. I think that it was clear how dangerous things were, and I think the leadership at the foundation said, who can we spare? And I was the one who wasn't doing anything productive in Seattle, and they thought they could send somebody out there. So I got to see some of the things that Paula was alluding to, the real challenge on the ground for responding to Ebola in a crisis zone, which compared to previous Ebola outbreaks that I've responded to, this one was even more apparent with the violence and the periodic attacks that have interrupted the response. We have watched in the last month with growing alarm the uptick in the epidemic curve and the increasing numbers of cases, but also some other signals that the epidemiology is not keeping up with the response. And some of the things that, Brennan, you pointed out at the beginning have caused us concern. One is the unusually high proportion of children, 30%, who have been affected in this outbreak. That's distinctly uncommon for an Ebola outbreak and points to the potential for transmission to children in healthcare centers by people who are not recognized to have Ebola. The uptick in the proportion of daily cases that are not coming from contact lists is a very concerning sign. It's continued, and it points to this possible pool of undetected spread that is contributing to the new cases but are not known contacts. And so these things have led us to believe that we need to step up our response and encourage others to do so as well. The two areas where the Gates Foundation, we do a lot of investment in technology. So Gabrielle talked about post-2014 research on Ebola, looking at vaccines, diagnostics, and treatments. And Gates, through CEPI, has invested in some of that work, and as have many others. And as a consequence, we have some tools that were not previously available. And in particular, we have vaccines that have not been a part of the previous containment. And so one of the areas we think we can invest in now is to accelerate the use of the Merck vaccine. It's now approved to be given as a fractionated dose, which means there's more supply available, and potentially in a different way, not focusing on the rings, but actually a targeted geographic vaccination, which would allow much more vaccine to be used, and for this surprisingly valuable tool to have an impact on containing the outbreak. And then the second area where we're focusing is on diagnostics, because we believe that the diagnostic testing has not been able to keep up with the pace of the outbreak. Focusing on strengthening the National Laboratory, INRB, and their ability to do more diagnostic testing, potentially adding in new diagnostic testing like rapid diagnostic tests, but to try and keep up with this probable pool of unrecognized Ebola cases that are transmitting to others is the second area that we're focusing on. So that's a little bit about what we're thinking right now, and most importantly, encouraging others to pay close attention to this outbreak and to do what they can.
Thanks, Scott. And, I have to take advantage of having you on the panel and maybe taking this opportunity to educate all of us a little bit more about the different strands of the Ebola virus. And as we know, this particular strand is the same that was witnessed in West Africa. But can you tell us a little bit more about this particular strand and why it is so deadly when compared to the, I believe, other 3 or other 4 strains of the Ebola virus?
Right, Ebola Zaire is the worst. It always has been, and it's caused quite a series of outbreaks, and the mortality in Ebola Zaire outbreaks tends to be higher than Sudan and the other subtypes of Ebola. This virus was sequenced early on by the National Laboratory and shown to be Ebola Zaire, and also to be distinct from the outbreak that immediately preceded it, which was in a distant part of the DR Congo. And so that was important early information. The mortality of this outbreak, as someone mentioned, is high. It's on the high end even for Ebola Zaire. It was tracking at about 62% or so for a number of months. It's ticked up in the last month. Now it's up around 66%, which is high. There isn't any evidence that the virus itself is more virulent than previous versions of Ebola Zaire, to the extent that that can be looked at. It says a couple of things that are of interest. One, although there are new treatments and there are 4 being tested, those treatments have not resulted in a dramatic decrease in overall mortality from the outbreak, although those who are treated have a lower mortality. And importantly, those who got the vaccine, even if they do come down with Ebola, have a lower mortality. It speaks to the fact that the high mortality speaks to the fact that a lot of the cases are not getting to treatment or not getting to treatment early enough. And then the other perhaps disconcerting thing that speaks to is potentially unrecognized living cases. So the mortality in an ongoing outbreak is calculated simply by dividing the number of deaths by the number of cases. And if you're under ascertaining cases, but you are swabbing and confirming deaths, that number goes higher. So it reinforces two things that I'd finish with. One, this is a deadly strain of Ebola to take seriously. And two, it's possible that we are incompletely ascertaining the total number of Ebola cases.
Thank you, Scott. And Paula, I just want to come back to you. You have your colleagues on the ground there, and we cannot ignore the fact that you and others on the ground are operating in a conflict area, an area that has witnessed conflict for, unfortunately, decades. Can you tell us a little bit about some of the challenges that you and your staff and more importantly, the community in this region are facing being in a conflict area while trying to address this emergency health crisis?
Sure, and thank you for that. And I'll just, again, I echo all of the things that Gabrielle and Dr. Scott have said about both in laying the foundation for how this is different from West Africa, but also, the challenges that we're facing in getting people to the treatment centers. So, working in an active conflict zone, it cuts both ways. Not only is it a detriment to the humanitarian actors, the international community, the NGOs that are on the ground, but also to the community members who are then trying to seek treatment. And what we've seen in the last couple of months, unfortunately, has been not only violence from the armed conflict that's already ongoing, and for a lot of different reasons, including political reasons, stemming from the presidential elections that took place in December, and we're still kind of undergoing that shift in leadership. So those are longstanding kind of ties. But then, towards Ebola responders, I mentioned before that there have been threats on our frontline workers. There have been threats to our health facilities. Health facilities were then damaged and sometimes destroyed in the process. And, interestingly enough, some of those health facilities were also destroyed by the health facilities themselves, because they did not want other community actors to destroy the health facilities further, which is very unique. And we've had those frontline workers come and tell us, well, it's better that we destroy them than they be destroyed by the community members. So it's very, very challenging. And so when you combine that to the fact that there's already this kind of disbelief that we're combating about Ebola and whether it exists or doesn't exist. And then you combat that with the fact that community members are literally risking their lives also to go to centers that could be attacked. It really exponentially affects the area. And some of the strategies that we are looking at developing now is how can we minimize the exposure that a community member has in getting to a treatment facility faster in their area, and minimize the fact that they, might go back into their communities. How can we ensure that they have local access to a facility, and they're comfortable in that environment, and with those health actors that are treating them. So I think the security aspect can't be downplayed, and it's not going to go away anytime soon. But we have to look at that as, it's a threat to both sides of the equation, not only humanitarian actors, but then the community members. And as I mentioned before, another challenge, is really just the resources that need to be made available. Gabrielle spoke about this when she said one of the critical points is early investment early on in an outbreak. And I think that we can be proud to say that we hit the ground running with a lot of lessons learned of what took place under the West Africa response. And so we did have some support from the international community. We were using those lessons learned. We had one of the strongest and most effective vaccines created. But, this is a prolonged response now. And we do need those resources to continue to come in, not only in human resources and people's time and capital, but also in, supplies that we need, protective gear that we need, basic and essential medicines that we need to treat this. And that's compounded in an area that has already several health concerns to start with. So Ebola is coming in and kind of shifting attention to all of these other issues that were already there to existing, both in primary healthcare concerns, maternal mortality rate, low, malnutrition, protection issues. These things kind of already exist, and now you have Ebola coming in and shifting the attention from health needs that are there and spending resources on those things. And these are strategies that we're all working to address.
Thank you, Paula. And I just want to remind the audience that if you have any questions, now would be the time to go ahead and get those in. Gabrielle, we do have one question that was already submitted to us, and they're asking, is it possible to help those on the ground remotely, whether that be, through providing ideas or, through innovation? And I know you and your team did a lot of work in 2014 in West Africa looking at innovation and looking at, developing new mobile health platforms or drones or having people, in Illinois getting together to help out with mapping for rural areas. Are there any things that you would like to highlight to, remind us what we all could be doing from a distance?
That's a great question, and I'll tell a brief story and then ask my other panelists to weigh in. When I took the job as the director of the Ebola Initiative 5 years ago, I described it as my first job in the LinkedIn era. And as probably one of the only people in the world that had Ebola in their title on LinkedIn, I was barraged with great ideas of people wanting to help. And so that was something that really pointed a bit of a gap in the system, that in today's world with our technology assets and ability to contribute in so many different ways to solve a problem, it's really hard to connect those good ideas in a garage in Palo Alto to the needs on the ground. And so that was something that we at the Paul Allen Foundation tried to proactively do by bringing together the people who really understood the needs on the ground with the people that had the great ideas. Sadly, I think it's still a gap today, so I don't have a simple solution for where you should go, but I might ask the colleagues on the phone if they have any resources of where people are collecting those ideas or where someone might want to go to support this. I would say at a last resort, you can certainly find me on LinkedIn and I will try and point you in the right direction.
Scott, let me ask you to bring you in, and anything that you can add. I know, Gates Foundation is also sort of a leader in investing in new technology, especially when it comes to health systems and infrastructure, but anything that you would add to what Gabrielle has highlighted?
Right, we're always open to great new ideas. And I know that Vulcan recently put out a challenge seeking innovative ideas to address Ebola challenges. And they got a good response to that. So there are some avenues that people can take to put new ideas forward. The fact is that we're in a better position post 2014 than we ever have been with Ebola, with 4 new therapeutics that are being tested in North Kivu right now. At least 2 vaccines, one that's been well used and one that's about to be used against Ebola, which has never been the case in previous outbreaks, and a handful of diagnostic tests and options for identifying cases simply and on the front lines. So these tools are valuable and critically important, but what we've learned from this North Kivu outbreak is that new tools are not enough, and that in the context of a conflict zone with mistrust from the population and a rapidly spreading virus, we also need the traditional tools that we have, shoe leather epidemiology, identification and isolation of cases, and just a good, robust field response. And that's what's been so difficult with the repeated attacks on responders.
Thanks, Scott. And Paula, we have about 3 or 4 questions that are kind of similar. They touch on community engagement and mobilization. And the question is how are the various partners responding to the crisis? How are they involving the community and listening to the community? And more specifically, how are they involving traditional healers or other local religious leaders and ensuring that, as Scott was talking about, we have the right messaging and that we are creating awareness within the community about Ebola and the challenges related.
Thanks. That is a great question and something that we're continually looking at as the humanitarian community, but also as the international supporters right now. The community resistance cannot be understated. It's been a difficult issue from the onset of the Ebola crisis, for political reasons, economic reasons, and others up until now. And, I think that coming in with such a strong lessons learned from the West Africa outbreak, it helped us in terms of leadership. It helped us in terms of protocol and organization and coordination. But I think that we did ourselves a disservice, I'll just say, in creating kind of a really heavy top-down approach where we kind of led the charge in saying, this is what we're going to do, this is the coordination, and that's not to discredit any of the efforts of the humanitarian community, us International Medical Corps included, because I think that it was really helpful to do that and understand, the strategies that needed to be in place to combat this. But, it is alien to a lot of community members. I mean, you're going in there with protective gear. You look like you're a space astronaut, and it's something that no one has really talked about before, and it causes fear. If you're seeing that as a young child, you could be fearful of the fact that people are coming into the communities and now all of a sudden saying, these things exist. So, and there has been, at least very early on and even now, a tendency to go to traditional healers, and therefore people come into the health facilities or treatment centers very late, at stage 2 or stage 3, when it's almost, too late for recovery. So, to kind of combat this, there have been efforts, both by International Medical Corps specifically and other actors, to create community platforms. And this is similar to what we did post-Ebola in Guinea, for example, and setting up community platforms where there would be different representatives of the community, women, local leaders, religious leaders, traditional healers, that could talk about what they're seeing in their community and give us, more importantly, feedback and how they would like to be treated, how they would like us to kind of go about the messaging and get that important information from them. So, us along with other trusted organizations are creating that effort. And I'll go back to what I said about the fact that, this Ebola epidemic is coming and compounding serious health, nutrition, protection issues that were already in existence before the arrival of any humanitarian actors. And so where we're going in our strategy is we're trying to also meet the communities where they are and engage with them on issues that are important to their communities, not only Ebola, but maternal mortality rates, malnutrition in their communities, gender-based violence, just to name a few. And in the hopes that in caring more about their holistic, health environment, that would also bring down some of this community resistance. So I hope that answered your question, but this is definitely something that we're actively working on as a humanitarian community.
Thank you. And we have one last question, Scott, if I may. It's similar to the previous question, but more specifically looking at the youth. And the question is, what are the measures, or what's the most successful measure for educating or creating awareness for the youth and the children? As you echoed earlier, we've seen a much higher percentage of children being infected during this current outbreak. So what are your recommendations or thoughts of how we can reach the youth and do a better job at educating them around the effects and the impact of the Ebola virus?
As we've looked at the data coming out of this outbreak and been alarmed by the large number of children who are affected, for the most part, when you look at the individual case reports, these children are unanticipated innocent victims. Again, for the most part, these are kids who are come down with Ebola, but on their history, they were at a health center 7 or 10 days earlier with an ear infection or a sore throat. And presumably, and otherwise, it isn't clear how they got infected. And so presumably, they're being unintentionally exposed at health centers to people who have Ebola but are not identified as such. And that's really just a tragedy, and it has not been a big part of previous outbreaks. In previous outbreaks, these outbreaks spread in people's houses and in towns and villages. And what people do when they have sick relatives in the house often is they send the kids to live with relatives. So while they're caring for their sick wife or husband, the kids are with the grandparents. And therefore, children have been spared in previous outbreaks. And that's not the case here, and it's a tragedy. So in terms of what can be done, we have to figure out a way to get those unidentified Ebola patients tested and identified so that they can be safely treated and isolated so that they're not infecting these kids and others unintentionally. And that speaks to one of the things I highlighted earlier, which is the need for an expanded and much better diagnostic testing program. And we are anxious to support WHO and INRB and the other responders in expanding their diagnostic testing, and I would encourage others to think about that as well, because the large number of children who are being infected in this outbreak is both unprecedented and really unfortunate.
Thank you, Scott, and thank you to our entire panel, Paula, Gabrielle, Scott. Thank you for very thoughtful comments and helping to educate all of us more about the current situation on the ground and what we as individuals and the philanthropic community can do to better support or further support the situation there. Last month, the Center for Disaster Philanthropy launched our CDP Global Recovery Fund. This is our exclusive fund for international disasters. As with all of our funds, we will be devoted to medium and long-term needs and catastrophic disasters, including natural and complex humanitarian emergencies, and this includes pandemics. We know from previous experience that the focus of most individual giving is in the immediate relief phase, but as our panelists have shared, there will be ongoing long-term needs to assist with recovery for many years to come in the DRC. You can find out more about the CDP Global Recovery Fund at www.disasterphilanthropy.org. To those of you who may be planning disaster response funding, CDP has many additional resources and information in our disaster playbook. You can find it at www.disasterplaybook.com. We also have created a list of suggestions for foundations to consider related to disaster giving that we want to share with you as takeaways today. First, we encourage you to take the long view. Even while focusing on immediate needs, we need to remember that it will take some time for the full range of needs to emerge. Be patient in planning for disaster funding. Recovery will take a long time and funding will be needed throughout. Also, recognize there are no places private philanthropy can help that government agencies might not. There are places where private philanthropy can help that government agencies might not. Private funders have opportunities to develop innovative solutions to help prevent or mitigate future disasters that the government cannot execute. Also, all funders are disaster philanthropies. Even if your organization does not work in a particular geographic area or fund immediate response efforts, you can look for ways to tie disaster funding into your existing mission. If you focus on education, health, children, or vulnerable populations, disasters present prime opportunities for your support. Lastly, ask the experts. If you are considering supporting an organization that is positioned to work in an affected area, do some research. The Center for Disaster Philanthropy can help you with this research if needed. Again, I want to respect everyone's time and keep us within the hour. So unfortunately, that will be the end of the webinar. Again, I want to extend my thanks to Paula, Gabrielle, and Scott for taking time to share their thoughts with us today and share their experiences and expertise. Special thanks again to the UPS Foundation for hosting this webinar and to our co-sponsor, Africa Grantmakers Infinity Group. And thank you to everyone that joined in and listened. If you have any questions or thoughts that were not addressed during today's webinar, you may email them to me directly at brennan.banks@disasterphilanthropy.org. Again, thank you. Have a great evening, afternoon, or morning.